Welcome, and thank you for joining us. I'm Dr. Carol Alexander, Head of Professional Relations at Johnson & Johnson Vision. On behalf of everyone at Johnson & Johnson Vision, it is our pleasure to sponsor Covalent Careers, and we're so pleased that they can bring you the Eyes on 2021 event. You showed up because you wanted to hear why lens selections mattered, explained by a legend. So I think maybe it's most fitting if I share a little bit about our legendary speakers. So we'll go to that next slide, and you see that I'm joined here by Dr. Lyndon Jones, the legend. Dr. Jones joins us from Canada, from Waterloo, where he is the director of the Center of Ocular Research and Education and a professor at the University of Waterloo. And most recently, just earlier this year, was named a distinguished professor. His CV is multiple pages long. You will know him as a continuing education speaker. You will know him as being published all over the place. And most recently, in this most unusual year, 2020, you will have seen him on the front lines of a discussion about whether contact lenses are still safe to wear amidst COVID-19. So give a little quick wave and hello, Lyndon, if you don't mind.
Hi there.
Hi, my friendly legend. And no slouch himself, my good friend, Dr. Kurt Moody. He joins us from Jacksonville. He's the Director of Professional Education at Johnson & Johnson Vision. But it's important to know that he was with J&J for about 15 years in R&D. And prior to that, some 20 years in the practice of optometry and an ODMD practice in Pennsylvania. And when I say he's no slouch, he's got a long CV as well. And you know, it's interesting, at J&J, the highest honor that we can get in R&D is the Johnson Medal. And my good friend, legendary Kurt Moody, is the recipient of the Johnson Medal in 2016 for his work in presbyopia on the optics and design of the moist multifocal lens. So gentlemen, it's really lovely to have both of you here. Kurt, if you want to say a quick hello, you're welcome to do it.
Hey, good afternoon, everybody. Thanks, Karen.
All right. So let's move into quickly the next slide. Isn't it nice that I get to tell the legend? Next slide, please. So here we go. What we really want to talk about today is, you know, why lens selection matters. And what I would encourage each of you to do is reflect on what does that question really mean? Why does lens selection matter? What does it mean to you? When I think about it, I think about the fact that patients today are armed with more information than they ever have been before. Oftentimes, they'll come into our practices with their own ideas about what lens is right for them. And we have a job to do. As optometrists, we have to think about that medical device in the important ways that matter. And that is about making our decision not about what modality a patient wants to wear, but more importantly, what do they need? And what does the science or the evidence tell us about what selection we should make? So we're going to cover that today. We also want to think about what can a manufacturer do? Can a manufacturer do anything with the creation of their lenses to make the wearer's experience better in a way that is meaningful and differentiated? And if you can, does that play into better hygiene, which is important all of the time, but certainly rises to the top during a pandemic like COVID-19? So we'll discuss that as well. And then what we want to do is wrap that all together at the end with just some brief conversation about the style of our communication with our patients when we're talking about the lens choice we've made for them and what we are going to prescribe. So those are the things that we want to cover on. But before we can get to the specifics, if we could go to the next slide, just a quick bit on how we'll get to your questions. It's a little bit difficult when you have such great speakers with such great content to do questions real time. So we've planned in specific times for Q&A. And I would encourage you to use the live chat feature below so that you can just type in your questions. I'll be collating them. And when we get to those question and answer session points, I'll make sure that we get as many of your questions answered as possible. So with that, Dr. Jones, I'd like to turn it over to you so that we can begin the discussion about lenses and the evidence.
Thanks, Carol. Thanks very much. Thanks very much, everyone, for joining us. As Carol said, I am based at the University of Waterloo, and some disclosures to begin with. We're very fortunate to work with all of the major companies working in this space. These are the current 18 companies and 3 funding agencies that we work with, but my presentation today is going to be very generic. So let's start by thinking about and looking at the contact lens fitting choices that practitioners currently make around the world. And in terms of getting to that information, probably the best information that we have is a survey that gets published every January in Contact Lens Spectrum by Philip Morgan from the University of Manchester. So let's take a look at the data for last year, which is the most recently published data. And the data that's out there covers a wide variety of fits, over 20,000 fits across 25 countries. So a very large sample. And what I've presented here is some information on 3 countries, but I'm just going to draw your attention to the far right-hand bar, which basically is the mean for all of those countries. So these are the average of over 20,000 contact lens fits, broken down by contact lens material. And you can see that around about 75% of all contact lens fit last year were fit with silicone hydrogel materials, so about 25% in hydrogels. And then I further subdivided that into whether they are reusable or daily disposable. And you can see that within the silicone hydrogel group, the majority of lenses that are fit are of the reusable type, so either 2 or 4 week replacement. But when it comes to hydrogel, it's actually been flipped. So within the hydrogel group, it's primarily daily disposable hydrogels that are fit. Now that information's vaguely interesting, but what's more interesting is what makes practitioners make those decisions? What information are they using, and what really evidence is there available for them to make that decision between whether they fit a hydrogel or a SiHy? And then when they choose that material, do they choose for the patient to replace them on a daily disposable, a 2-week, or a monthly basis? And what we did, so myself and Kurt, who's going to be the next speaker, along with a colleague of mine from the University of Waterloo, Karen Walsh, is in exactly a year ago, so November of Contact Lens Spectrum last year, we published a paper looking at the evidence around how we can make these prescribing decisions. So for those of you who are interested, if you go to Contact Lens Spectrum on the web and go to last November's issue, then you'll be able to download that article. So what we're going to do is we're going to look at what evidence is there to help us make those prescribing decisions in new patients. And we're going to divide it up into 2 groups. We're going to divide it up into the initial history and symptoms, so the information that we glean from the patient in just a discussion format, and then we're going to look at the evidence around the clinical tests that we then do. So let's start off with the initial history and symptoms. Now, there is no doubt about the fact that there are some questions that we can ask which will be helpful in our prescribing decisions. Some of those relate to things like health and medications. We know that CIE events, so infiltrates, are higher with some chronic conditions and also with smoking. So in those situations, we might be thinking about using, for example, a daily disposable. There is evidence that would support that. Ask about allergies. There is excellent information out there that seasonal allergy, or those patients with seasonal allergy, are actually more comfortable in a daily disposable lens, in particular a hydrogel lens. 2 publications support that. If the patient has a history of ocular surface disease, or when you examine them, you find that there are infiltrates in the cornea, then again, we know that the risk of developing SCE subsequently is higher in those patients. So again, that would support probably the use of a daily disposable. We also have good evidence related to their hygiene and occupation, that their CIEs are associated with substantial bioburden on the lenses, and the risk is increased with work in which the patient is exposed to dust, wind, fumes, or water. So again, probably helping us look at using a daily disposable of some format. The final thing relates to symptoms, and I don't think necessarily we're that good at asking a brand new wearer about the symptoms that they have. We would always ask that question when we follow them up, so when they are wearing the lenses and they come back for a progress check. But is there any evidence or any benefit to asking patients about how their eyes feel before we fit them with lenses? Now, the way that we can glean that information is a couple of different ways. We could simply ask the patient, hey, do your eyes feel dry? Do they feel irritated? Do they ever feel uncomfortable? So just simply ask those questions around symptomology prior to lens wear. Or we could use a validated questionnaire. And most of the information that's out there with respect to prior contact lens fitting and a validated questionnaire is around the OSDI. So the OSDI, we can either ask that in a paper format, or actually you can in fact download that as an app. So if we ask that question around patient symptomology, or grade their symptoms using the OSDI, does that help us in our prescribing decision around material or frequency of replacement? And actually, when we do that, when we look in the literature, actually it doesn't. There is no information out there that will help us make those choices between material or modality. But nonetheless, it is still worthwhile asking, because what we do have is good evidence around the fact that if a patient has a higher OSDI score, or they report more symptoms prior to lens wear, then they're more likely to be what we call an intolerant wearer, or someone who reports symptoms when they go into lenses. So it is worthwhile asking the patient, because it could well basically set up the expectations for that patient. Maybe you're not going to be able to wear your lenses for 16, 17 hours, 7 days a week. Maybe we'll have to cut back on that wear time, or maybe you'll have to not wear them so many days a week. So it is worthwhile asking, but doesn't really help our prescribing decision as such. Now, in terms of whether we choose between a hydrogel or a SiHy, something that will help us make those decisions relates to the amount of oxygen getting through to the eye. So for example, if a patient is a high myope, a high hyperope, if they're going into a thicker lens design, so maybe a multifocal or a toric, or if they're going to be using the lenses on an extended wear basis, then of course that drives us down that silicone hydrogel route. Another thing that's very important to ascertain at the initial fit relates to things like occupation and things like social or expectations around how often they're going to wear them as well. And that replacement frequency is often driven by responses to those questions. So for example, if the patient is a first responder, they're a high prescription and they're going to need to be able to wear their lenses and be up and at them straight away, then again, that might lead us down the continuous wear or extended wear route. If they're only going to be wearing their lenses a couple of days a week for sport or for social events, that's more likely to drive us towards a relatively infrequent use, or maybe daily disposable as an example, if they're only going to wear them a couple of days a week. So those are the kinds of questions that can help us decide what material to fit and what frequency of modality during the initial questioning. Okay, now let's think about moving on to the clinical exam. Of course, we've done the history and symptoms. Now we sit the patient down and we start doing a clinical exam at the slit lamp. What evidence is there out there that will help us choose between the modality and the material? Well, one of the first things that we would always think about doing is breakup time. And we usually measure tear film stability or tear breakup time when we look in the literature, sadly, there isn't anything. These are 3 reports that have been undertaken trying to look at contact lens success relating to tear film stability using non-invasive breakup time measures. No help in terms of choosing material or indeed frequency of replacement, but again, worth doing, because very good evidence that in those patients who have a shorter non-invasive breakup time, they're more likely to be symptomatic, and we should have that conversation early about the fact that maybe we need to temper the patient's expectations. Okay, so that's tear film stability. What about tear film volume? And again, one of the things that we always, or at least very frequently in a new wearer, would want to measure. So when we think about measuring tear film volume, kind of typically 3 ways of doing it. The Schirmer test can be very irritating, can produce excessive tearing, maybe not the best test. What about two less invasive tests? What about things like phenol red thread wetting length? So less invasive than Schirmer, does give us an idea of tear film volume, or indeed a very non-invasive method, things like just looking at the tear meniscus height at the slit lamp. Again, what evidence is there that doing that helps our prescribing choice? Well, again, there isn't any. Sadly, there is no evidence to help us make the prescribing choice, but again, worth doing. Good evidence to show that if we have a lower phenol red thread wetting length and a lower tear meniscus height, that patient is more likely to be symptomatic. So at the moment, we don't seem to actually have anything that's particularly helped our choice of prescribing, but good things to do because it can help us decide whether the patient is going to be relatively asymptomatic or not. Okay, what next would we do? What else might we think about doing? Well, fluorescein. Assessment of corneal staining. Surely there's got to be something in the literature that if we see a patient with lots of fluorescein staining or not on the cornea or the conjunctiva, that's going to help us. Again, when we look in the literature, sadly, nothing there. Even when we optimize the way of doing that by using a yellow barrier filter, there's relatively little information linking the amount of corneal staining to discomfort. And at best, frankly, there's a weak link between contact lens discomfort and the degree of corneal staining. And again, not to say that we don't do it. We should always assess this in patients, but it's not going to help us choose between what material we want to prescribe or frequency of replacement. Okay, what else? Lids. Very important that we look at the lids for sure. Absolutely no doubt about the fact. And when we look at things like lid hyperemia and lid papillae, so how smooth the lid is and how red it is, if we see that in a brand new patient who is going to go into lenses, that might put us onto the fact, well, maybe this patient's got allergies. And I've already mentioned the fact that any patient with allergies, we're going to probably be looking at prescribing a daily disposable. And there's evidence in the literature that a hydrogel daily disposable can be beneficial in those patients. Well, in addition to the palpebral roughness and color, what about the external portion of the lids? What about things like blepharitis and meibomian gland dysfunction? Again, really important that we look for these in a brand new wearer, because we know when we do that, these patients have a higher amount of gram positives on the lids, and these patients are more at risk of developing infiltrates. Another thing that I think we're not very good at doing is assessing the meibomian glands. Now, there's a number of different ways of assessing the ability of the meibomian glands. We could push on them to see how easy it is to express the oil. We can image them using a wide variety of methods to see what that looks like. Is there any evidence in the literature that by doing this on a brand new neophyte before they go into lenses, that it's worthwhile? Because I don't think typically we would do that. We'd probably do it on an existing wearer, but what about a neophyte? Well, interestingly, there is some evidence, not to help us in our prescribing decision for material, but there is for frequency of replacement. In patients who have active meibomian gland dysfunction or active blepharitis, the choice should be a daily disposable lens. No evidence in the literature about which material is best, whether it's a SiHy or a hydrogel, but certainly good evidence that moving to a daily disposable is what we should be doing. What about other aspects of the lid? What about things like lid wiper epitheliopathy? Now, this is one of the newer things that we've been looking at. We've been looking at this extensively, both in dry eye research and in contact lens research. So if we look at the lid wiper area using either fluorescein or lissamine green, does that help us make our decision in terms of material or modality? Well, again, actually, no, it doesn't. Sadly, it doesn't help us with our prescribing decision. But what it does help us is that we know that this is related to friction. We know that basically as the lid wiper goes over that cornea or goes over the front surface of a lens, that the amount of lid wiper epitheliopathy that you get is closely related to friction. And we know that we have some materials that have a very lubricious, very wettable surface, which reduces the amount of friction between the lid, the undersurface of the lid, and that surface. And as Kurt will talk about in a minute, that's actually a very useful thing to assess. So do assess lid wiper epitheliopathy, because that might help us choose the material in terms of selecting a material that has a low level of friction. What about this? Now, again, some of us might think, oh, well, you've done that already. You've covered that with blepharitis. This isn't blepharitis. This is another condition. You can see the very characteristic collarettes there. And that cuffing along the margin there is because of this little beastie. This wee beastie here, which, of course, we've seen in many patients. And this basically is the presence of Demodex. Demodex is one of those things, again, that relatively been around in the literature for a long period of time. We're not very good at looking for it in new contact lens wearers. Very easy to detect. Basically, if you just take your forceps and move the lash around, you can see this Demodex basically backing up out of the hair follicle. Again, does that really help us in a new contact lens wearer? Well, I'm going to share two pieces of information for you because actually it is very useful. We know that in contact lens wearers, they have more mites than in non-contact lens wearers. And a very important graph is the one on the right-hand side. And that basically looks at a whole bunch of contact lens dropouts and a whole bunch of asymptomatic contact lens wearers. And what we see is that in a significant proportion of contact lens dropouts, the number of patients with an overabundance of Demodex is significant as compared with asymptomatic patients who have virtually no overabundance of Demodex at all. So again, very important to look for both in your existing wearers, but in particular in patients who are about to go into lenses, because if you do find Demodex, treat that Demodex before they go into lenses. If you don't, then those patients are highly likely to have problems with their lenses and drop out. So in summary, when we're looking at fitting brand new contact lens wearers, there are a number of things that we need to ascertain to try and help us select the lens material and the frequency of replacement. Ask your patient very careful questions about their expectations of lens wear, about the environment in which they work. Look at the tear film stability and tear film volume, but most importantly of all, look at the lids. And again, I don't think necessarily in the past we've been good at doing that, but that's probably one of the things that can actually help us in select both our material and frequency of replacement. So look at the lids, things like lid wiper, meibomian gland dysfunction, blepharitis, Demodex, really important. And with that, I'll say thanks. Thanks very much, Carol.
Thank you, Lyndon. And it is time for some questions from the audience. And as I wait for those to come in, maybe I'll just ask one of my own.
Sure.
When all of us have the chance to talk to doctors across the country, whether it's at a convention or just connecting time, there seems to be a lot of desire to simply move into a silicone hydrogel. And I really enjoyed your conversation today because I took away that there's really still a great opportunity for us as clinicians to look to a hydrogel material as being valuable. And so I wonder if you might comment a little bit. You were talking about allergies and how important a hydrogel lens may be in that group. But then you also talked about if somebody has a high RX, that might be more suited to a SiHy. So how do you balance that when you're thinking about that patient who is an allergy sufferer, but also may have a high RX?
Yeah, that's a great question, Carol. And actually, when we look in the literature, the only two papers that have looked at allergy performance with contact lenses happen to be with daily disposable hydrogels. Now, that's not to say that daily disposable silicone hydrogels won't work extremely well. It's just that at the moment there isn't any literature to support that. I personally have fitted many patients with daily disposable silicone hydrogel lenses who have allergies, and they've been very successful with them. So it's not a case of it doesn't work. It's just that at the moment, actually, that experiment's not been done. So we don't have any negative data against it. We just don't have any positive data to support it as we do with hydrogels.
Understood. I wonder too, just was thinking about MGD because you mentioned that as well and talking about daily disposable and that material. But, the recommendation there also seems like really a patient could be served with either silicone hydrogel or a hydrogel.
Yeah, absolutely. And again, it comes back to that, I think there's a whole generation of people who've grown up who think that, basically silicone hydrogel is the lens that we should fit absolutely to everybody. And certainly I've been very successful and we've published a lot of data on silicone hydrogels, but sometimes there are some patients who just, for whatever reason, and we don't understand why, just aren't able to wear a silicone hydrogel. And we do have a group of people who actually do extremely well with hydrogel materials. And so again, it's that interaction between the material and the ocular surface, the quality and the type of tear film that patient has. A lot of work still needs to be done in that area in terms of, it would be great to be able to look at a patient and go, you're going to do better in a hydrogel than a SiHy. But at the moment, we just actually don't have that data.
Carol, do you mind if I just chime in?
I was just going to ask you to. So
I know just a little bit about MGD, and I think this is a pretty important statistic, and I think this would be great for the audience to know. For a patient to be asymptomatic, they need at least 9 functioning meibomian glands if they're wearing contact lenses. So 9, I mean, that's quite a bit on that lower lid. If you're a non-contact lens wearer, you need at least 6. So I think that really describes very well to us why sometimes we have that contact lens patient who they describe dry eye irritation with their contacts in, but they say, when I take them out, I feel great. And my communication with those patients is always, this is actually a great barometer, because if I don't start to treat your MGD now, the way you feel with your contacts is the way you're going to feel all the time. So it's a great opportunity for us as optometrists to get in there and intervene. So remember those 2 numbers. 9 you need if they're a contact lens wearer, 6 if they're a non-contact lens wearer, if they're asymptomatic.
Thanks for that. And I think it's great to give those kind of numbers for people to think about. But you know what else I'm reminded of? And I can ask this of my legendary friends, because to be legendary, it means you've been around the block, we'll just say. But, in the good old days, we always everted the lid to look for GPC. Perhaps not doing that so much anymore, but what's your recommendation? This will be our last question. What's your recommendation on what anybody should do with respect to identifying MGD before they get started with contact lenses?
It's really important. There's no question about the fact that we're seeing a greater number of patients with meibomian gland dysfunction these days. As more and more people are using their digital devices more, we're seeing less blinking. That pump mechanism is being reduced. We're seeing a lot of people who are in their early teens who have meibomian gland dysfunction. That just never used to happen. So I think it's ever more important now that we assess those meibomian glands in every primary care patient, as well as every contact lens patient, and in particular, those people who are complaining of symptoms. We used to always think that, basically dry eye was probably caused more by an aqueous deficiency than an evaporative case. That is not the case at all. The vast majority of dry eye is due to evaporative cause, and evaporative causes are primarily linked to meibomian gland dysfunction. So really important to check those meibomian glands.
I said that would be the last question, but we did just get another one sneak in here. So let me just ask it. And Kurt, you could answer it, or Lyndon, you could answer it. But the question comes in that in the clinical setting, when you have a patient who is burdened by financial concerns and they ask for a particular lens, if it's not the one that you want to recommend, how do you get by that desire where the financial implication seems to be the thing that's most important to the patient?
Linda, do you want to take it, or do you want me to jump in?
No, I think you should jump in there, Kurt. I think it's your turn.
Good. And I think that's a great question, Carol. I think our role as clinicians is to educate. So, before I start to make a recommendation to a patient, I'm going to look at the holistic patient. And Lyndon did a great job summarizing all those clinical endpoints I think that we should be measuring before we make that decision. And typically, I'll be honest with you, I usually have 2 lenses in mind. I'm going to have that premium lens. I think that lens that's really going to satisfy that patient best. But in my back pocket, I'm going to always consider, what if that patient can't consider that or can't afford that lens? I think you should think of your backup lens there, almost like a best and a good option there for that patient. But I think first and foremost, I think educating the patient on why you're going to make a recommendation. let them know we could fall back to maybe the second choice, but realize what you're going to give up. I mean, I think it's very similar to the patient that walks in to, let's say, a family doctor and says, you know, I really think I need this medication. Is that doctor going to sit there and just write the prescription? No. You know, just because they went on WebMD to see a diagnosis and a treatment, they're going to first of all assess the patient and come up with their recommendation and have a conversation. I mean, the conversation with the patient is the key.
Yeah, I like that. And I think that you're absolutely right. You are not failing the patient if they don't end up in the premium lens that you prescribe, but you do fail them if you haven't made them aware of what would be in their best interest based on everything that you know. Because let's face it, they're paying you for your expertise. So you need to still take that high road. And I think that you addressed that beautifully. And in order to get through the next bit, I think what we ought to do now is maybe just shift over, Kurt, to your session, part of the session here. So we'll get into what a manufacturer can do in the way of creating lenses that are best for patient comfort, and how that might also dovetail into the benefits in hygiene.
Perfect. Thanks, Carol. And Lyndon, if you don't mind just going on to the next one. So, you know, we're going to really talk a little bit about contributors of comfort, but to really start this off, I'd like to talk to you about contact lens hygiene. And, you know, obviously hygiene is top of mind for us as physicians, and is definitely top of mind for our patients. So when I created the slide, really, I'm thinking about contact lens hygiene in regards to two aspects. And what I'm showing here on the left arm, is the contact lens safety profile. And, you know, and this is well documented. You know, we know daily disposables without a doubt are the safest way to wear a contact lens. You know, Lyndon talked about a number of attributes of why you would want to go there. Then we have daily wear reusables. And then, as we know, the riskiest way to wear any lens is extended wear. So it would be wonderful if we were just fitting robots that followed our directions perfectly, but that's not what we do, right? We're fitting patients. So we have to think about the patient perspective here. And Lyndon, if you go to the next click here for me, and that's really what we've got here on the right side of this particular graph. And that's what we're calling patient modifiable factors. And this is some work that Philip Morgan out of the United Kingdom actually created in 2011, but still absolutely relevant today. He identified these 8 factors, 8 things that our patients do that are directly correlated to the risk or the success in a contact lens. And if you look at them, they make sense, right? You know, topping off solutions, wearing a lens overnight if it's not been prescribed, not cleaning your case appropriately, which, to be honest with you, only 3% of the population do that correctly. But you see, I've got hand washing there. And again, hand washing, how much are we hearing about it now? A tremendous amount, as we should. And the reason we're calling out hand washing is because one of the things we know, and this came from Mark Wilcox out in Australia, the 2 areas that have the biggest, or that harbor the most amount of bacteria, are the tips of our fingers and our lower eyelid. So when we think about those 2 areas in regards to what we're doing when we're handling contact lenses, you could see how important hand washing is. The concern is that you could have the potential to inoculate your eye with an unwanted pathogen if you reach up there and maybe rub your eye. But Lyndon, if you just click once again, so why would you do something like that? Well, we believe there are these compensating behaviors, things like rubbing your eye, touching your eye, or moving your lens, that have the potential to introduce those pathogens. Well, why would you do that? Well, you know, we reached out and we surveyed a little over 1,500 patients. And if we go to the next slide, you'll see the results of that survey. Out of those 1,554 patients, 89% of those patients, and if you just click again, Lyndon, I think this might be animated, 89% of those patients told us that if they have an uncomfortable contact lens, they will reach up and they'll rub their eye, they'll use eye drops, or they may manually adjust their lens. I mean, think about that toric patient where things are a little out of focus. What do? Typically go up there and rub and move and try to relocate that lens. I've seen just even spherical patients do the same. They'll push it off and let it come back in. So you now see there's this correlation of compromised comfort possibly causing compromised hygiene. So what is it about a contact lens that could potentially cause or improve or have a relationship with comfort? Well, we've identified what we call four pillars or four contributors of comfort. The coefficient of friction of the lens, how slippery or how lubricious the lens is, the edge design, the wettability of the lens, but specifically the wettability to our tear film components, and the modulus of the lens. So it's really the interaction of those four parameters, those four contact lens properties that lead into the comfort of a contact lens. I'm going to dig deep into two of them. So let me just briefly, though, talk about the other two that we really won't go into. So lens design, what we know about that is the infinity edge that AccuView has on every lens has been proven to be the most comfortable lens. So there's been a number of studies, it's in the literature that that is the most comfortable. And why? So Lyndon introduced the concept of lid wiper epitheliopathy. We blink 12 to 14,000 times per day. So you want to have an edge that is as smooth as possible and has that very, very smooth infinity edge so the lid could easily go right over it and not cause that micro trauma that leads to lid wiper epitheliopathy. Modulus, or just how soft and how well a lens could conform to the eye. In general, lower moduli is more comfortable. It adapts to the eye, it'll wrap to the eye easier and have less ocular trauma. At the same token, we've got to be a little careful with modulus because if it goes too low, it does affect handling. But now let me get into coefficient of friction and wettability. So Lyndon, just the next slide, please. We'll introduce coefficient of friction. And really this came to us from the orthopedic world. So microtribology is actually the science of determining just how lubricious a material is. And you can understand why it started with the orthopedics world because they're creating artificial knees, artificial hips. It's really important for that joint to be very lubricious. Well, we realize we have the same thing going on with our eye. The eyelid and the surface of the lid has that same critical feature there. So that's where we started working in microtribology. And we reached out really to the people who are the leaders in this. It's a group called SUSOS in Switzerland. And the center image here is the experimental setup on how they measure coefficient of friction of a contact lens. Take the contact lens and they'll put it on a pedestal. They'll then bring this tip down, and the tip has a glass oval end on it that's covered with mucin. Now, the amount of force that comes down onto that contact lens is the amount of force that we know is exerted by the lid to the eye. Then that tip is moved back and forth, and after 100 cycles, they measure the amount of force that's occurring, the amount of friction. The lower the friction, the more lubricious the surface. Now, when they're moving that tip back and forth, that entire apparatus is dropped down into a vat of what's called tear-like fluid. That's composed of mucins, aqueous, and lipids. So you can see this experimental setup mimics what we have in the eye. Remembering, lower coefficient of friction is more lubricious. So let's look at some actual data. So if we go to the next slide, Lyndon, this will show the coefficient of friction of the AccuView contact lenses. Oh, just the other way. There we go. Perfect. So what we've got here is, if you look at that x-axis, you're going to see I've got different hours, 0, 6, 14, and 18. And the way the experimental setup was set up to do this was 0 hours is the measurement directly out of the blister pack. Now, after that measurement is taken, the next thing they'll do is they'll take that entire apparatus that's in that tear-like fluid and they'll pull it out for 20 seconds and then drop it back down for 20 seconds, up for 20 seconds and down for 20 seconds, basically simulating the blink. And they'll measure it at 6 hours, do the same sequencing, measure it at 14 hours and measuring at 18 hours. So what we're showing here is what occurs throughout the course of an 18-hour wearing time. So looking at the data in green is the data for our AccuView 1 day, Oasis, and the data in blue is the 1 day AccuView Moist data. Now that little red line that's going across, that's the coefficient of friction of the natural cornea, 0.015 of the natural cornea. So really what you want to do is you want to create a contact lens that mimics the coefficient of friction of the cornea. And as you see, the Oasis data stays at or below that throughout that entire wear cycle. And Moist is just a tad bit above. The other thing I draw your attention to are those error bars, that standard deviation. That tells you how much lens to lens repeatability there is And as you see with this data, it's incredibly tight. So it's really important that what we're looking at is throughout the course of the day. Now, we've measured competitor lenses, and to be honest with you, a lot of them they all look about the same at 0 hours with hours. So that tells us out of the blister pack, all lenses have fairly low coefficient of friction. But the difference between ours and so many of the competitors is through the course of the day. So my take home to you is always look at what that performance is more towards the end of the day. So what can we tell you in regards to, is there a correlation of this data to actual clinical data? And if we go to the next slide, we'll see that. So Noel Brennan, when he was an independent researcher in Melbourne, Australia, created this data. And what he did was he measured comfort on a 0 to 100 scale, 100 being the most comfortable, 0 being the most uncomfortable. And then he looked at the coefficient of friction of that material. And you see there's a very strong correlation. That R-square value of 0.8023 tells us that that correlation is extremely strong. So if we go to the next slide, I'm going to just address a little bit about wettability. What is wettability? Well, in the lab, we measure it with a test method known as sessile drop, which is our next slide. So sessile drop is actually using a buffered saline drop and bringing it down to the contact lens and measuring the angle that forms between the lens and the bubble. The lower that angle, the more wettable it is. But what's really important is the wettability to our tear film. Now, the wettability that we have with our lens, with the AccuView lenses, is brought on by the PVP, our internal wetting agent. So let me just talk a tiny bit about that, which takes us to our next slide. So, PVP is a very unique molecule, and I've got the molecule here on the left. What we use is a type of PVP known as K90. So K90, we've got a patent on, and K90 refers to the molecular length of that particular molecule. And we know having a consistent molecular weight throughout the contact lens gives very, very consistent performance across the lens. Well, what's unique about PVP is that it's amphiphilic. So Lyndon, if you just click once, what we'll see is on that molecule, you'll see that there are hydrophilic and lipophilic points on that particular molecule. And that's exactly what we have in our tear film. In our tear film, we have both hydrophilic and lipophilic elements in our tear film. So our PVP is what's known as amphiphilic, meaning it's got both of those endpoints. And again, that's the reason why it's so tear-like, because the molecule is mimicking what we've got within our tear film. It's also known as a demulcent, which means that it has mucoprotective properties, and it's a humectant, meaning that it's going to absorb and pull water into the lens, but not do it by dehydrating the tissue around it. So I think you see PVP on paper looks great, but what's the clinical data that it's going to do something? And that's our next slide. Now, this was some work that was done in Japan by an ophthalmologist known as Dr. Ko. And what Dr. Ko did was she identified a 26-year-old female that was known to have contact lens-induced dryness. She fit that patient with 1-day AccuView moist in one eye and 1-day AccuView in the fellow eye. So why is that unique? Because the lenses are identical. They were both a minus 0.50. The only variable that's different is the moist lens has PVP in it. The 1-day AccuView does not. So it's the ideal experimental setup in the fact that we only have one variable that we've changed. She then had the patient go in front of her aberrometer, and she was looking for higher order aberrations and measuring them every second over a 10-second period. Now you could see as early as 4 seconds, we start to see a difference where those higher order aberrations start to become noticeable in the 1-day AccuView lens, but not the moist lens, and see how big it is at the 9th second. So those higher order aberrations are a great surrogate for telling us we've got tear film instability. So this is the clinical data showing us how important and how relevant PVP is in keeping a consistent surface to our contact lens. So Lyndon, our next slide, which is really our wrap-up slide here, and it really talks about the mantra, what we try to do in R&D at J&J, and that is to consistently reduce that on-eye friction. If we can mimic the natural ocular condition, then we're going to get an ideal contact lens. And the best way to do that is by reducing that on-eye friction. And I think you see how we're trying to do it with our edge design, with our modulus, with our wettability. All of these factors are creating that very lubricious surface. If we could actually get to the level of the human eye, we've got a great lens. And really what we're striving for is to actually do better than the human eye. And I think it's well within the grasp. I think we could possibly get there. So Carol, I think we're probably at the questions section. So if any questions have come in.
So again, first of all, thank you for that. And thank you for really sharing the AccuView story. I know you've been involved in that in your years in R&D, so really have a command of what goes into making the lenses as they are. One of the things that you touched on, and I thought I would take us back there because I get this question a lot at the exhibit booths and other times when I meet with docs, but you know, you talked about NVP and you talked about PVP. Mm-hmm. Isn't it true that NVP can be long molecular length? Can't you get the same kind of comfort because NVP is the building block of PVP?
Yeah, and that's a great question, Carol, because we do know, for instance, the Bausch & Lomb lens uses NVP. Now they kind of tout that the fact they've got PVP, and the basis behind that is NVP is a building block to create PVP. The only issue that you end up dealing with if you try to go down that route is, you know, they're putting NVP into their polymer mix. And then during the polymerization process, the hope is that that NVP is going to convert over to PVP, but it does it at varying different molecular lengths. So if you end up getting PVP at a K5, a K90, a K125, that means you're not going to get consistent wettability, consistent coefficient of friction over the surface of the lens. So almost think about your windshield wiper going when it needs to be changed, and how it's going to be smooth and it's going to hit a rough spot and then be smooth again. And it's that start and stop that becomes pretty problematic.
I think that's a really great kind of description of what's going on there, because I do think sometimes we get sort of flummoxed by that conversation on NVP. And really, I mean, you can speak to this, I believe, but the long chain is unique to the AccuView brand. Is that not right?
It is. And I mean, where did K90 come from? I could tell you back, you know, in the 90s, we looked at all different molecular lengths to find out what would be the most eye-friendly molecular length that would work best. And that's where the K90 was selected.
Mm-hmm. You know, and another question, I was just kind of thinking back through the conversations that we had at the beginning, and you touched lightly on edge design. And I know that I've also been asked about the fact that, you know, some patients will have evidence of the edge on the conjunctiva, staining mm-hmm. around the edge. Should that concern anyone?
Yeah, so, and you're right, our invisible edge, the one thing that's actually been noted is you'll actually get some conjunctival staining. And the reason that you get that is because that really thin invisible edge will actually go down into the conj and we'll see some staining. You know, it's actually not true fluorescein staining, it's fluorescein pooling that's occurring there. And again, there has been actually no association. If anything, there has been one report where it seems to almost be a benefit in regards to reducing some adverse events. But again, that was only in one study.
So I think really what you've managed to share with the audience is that it really takes a balance of properties. It isn't one individual thing that makes a lens great or not great, right? So it's how do you get that balance right so that you have ease of handling, comfortable wear, and then really touching upon, which I thought was important today in particular, but just what happens when we're uncomfortable. And so much of hands by face, which is what we don't want to have happening during this pandemic. And I think maybe, Lyndon, I'll just kind of pitch to you a little bit. You know, if there's anything that you'd like to share with the audience with, you know, thinking about the pandemic, thinking about COVID-19, I know that there's some hesitancy on the practitioner's part in some places. Should they even put a new patient in contact lenses? Is there anything that you can offer in terms of some advice there?
Yeah, that's a great question, Carol, and it's certainly been brought up by a lot of websites in For Sure, and also by practitioners. And I think it's two aspects. One is it safe to go into contact lenses for the patient at the moment? And that was the subject of a lit review that we did back in April. And there is absolutely no evidence at all about the fact that this pandemic is causing more of a problem for contact lens patients. So long as contact lens patients remain vigilant in terms of their hygiene, then the risk associated with contact lenses now is no different to what it was prior to the pandemic. The other issue relates more to the concerns around fitting patients in practice and about whether that close proximity may produce an issue for the practitioner in terms of if the patient happens to be an asymptomatic spreader. And that is a concern. We do know that there will be some patients who are asymptomatic. The biggest concern really is around the instruction, so around the application and removal process. And there are ways of mitigating that length of time that the patient needs to spend with the practitioner. Of course, things like wearing a mask for sure, both the patient and the practitioner. Goes without saying. But again, things like asking the patient to view an application and removal video either in the practice on an iPad before they physically sit and practice it, or do that at home. There are many websites now that can allow the patient to see what it is that they're going to be doing, and then putting up things like shields in the area where the support staff person or the practitioner is teaching the patient. So I feel at the moment that there are great benefits, as I always have, to wearing contact lenses, particularly at the moment around spec steaming up. I'm a spectacle wearer, and when I'm wearing my mask, my specs get steamed up all the time. I think that I'm much, much happier wearing my contact lenses, and we have seen in surveys from patients how much happier they are wearing their contact lenses compared with a spectacle. So I think now is just as good a time as ever to be thinking about proactively recommending contact lens wear to our patients, and that we shouldn't be concerned about those risks at all.
Really great advice. And I would just tell our audience, J&J has put together for you an on-demand 24/7, at least in the US, Lyndon may not be familiar with it, but Lens Assist. And it's an opportunity for live chat and assistance and some really great resources on how to apply and remove lenses. So be the person who tells those patients about it's free to you, free to your patients, and really a well-designed tool. So AccuView.com/Lens Assist. He didn't know that he was giving me that little baton pass for a commercial, but I can't let that go without sharing that with you because it's really valuable information to the practice. One other question that came in from the audience, gentlemen, and it is, in spite of advancing technologies and lots of good material properties, we still have patients who come in and say, I just like what I used to wear. I like my older lens. So what do you do in those kinds of situations?
I think what you want to do is maybe understand what it is about that older lens that might perform better for them. And I think the person who asked the question is absolutely right. Although we've got some great new technologies, there are patients that still do tremendously well with AccuView 2, for example. And you may introduce them to a newer lens and they may say, hey, I liked my old one, and that's okay. But I think you've done your job as a great clinician in letting that patient know there's something new. Let me see if it's going to work for you. I think it might, and see how it goes.
What I found really interesting on that actually is, I think it's relatively rare these days. Those are the ones we just seem to remember, because they're the ones that are like, oh, why did I ever bother doing this? But what we see a lot more of are those patients who come in for their routine follow-up. That, you ask them about, are they comfortable with the lenses? Yeah, I'm get along fine. Say to them, hey, I've got this new lens. I wouldn't mind you trying it. I'll give you a call on Friday, see how you get on. You give it to the patient, and then on Thursday, they're calling you going, you know what? I thought my old lens was good. I didn't know how good it could be because this new one is so much better because I've now got a comparator. So I think that, yes, you will sometimes be caught with a patient going, you know what? I don't care whether you tell me this lens is better for me. I love my old one. That's far fewer than the people who say, I thought my old stuff was good. This new stuff is better. I just never knew how good it could be. So don't get turned off by not using new technology because of the fear of being, oh, I wish I'd left it alone.
Thanks for that. We are running up on time, Kurt. So I think what I'd like to do is just shift over to the next slide so that you can take us through the AccuView portfolio resources.
Yeah, wonderful. So, one of the things that we're asked all the time is, what's the right AccuView contact lens for me? And because of that, we've done some work and we've actually created a decision tree, which I'd like to introduce you to over the next 2 or 3 minutes. So Lyndon, if you just click the next slide. And, and we're fortunate that we actually have a little introduction on page 1 from the legendary Lyndon Jones. and it really goes into the fact that we truly believe at J&J that contact lenses are medical devices, and there's an art to fitting those lenses, and they should only be done by a licensed doctor. And that's really what Lyndon is summarizing here in his introduction. So if we flip to the next page of this, you're going to see information on, the 4 contributors of comfort that I called out, and a little bit of a blurb on what we do with our blink stabilized design and our personalized pupil optimized design. But let's actually get into the nuts and bolts of the decision tree. Here's the decision tree that we've got in regards to daily disposables. So in my opinion, and I think in most doctors' opinion, if cost and if parameters was not an issue, we would fit everybody with the daily disposable. And that's really what the first decision box is. Is this prescription available in a daily disposable? If the answer is yes, you see that next box says, are any of the following present? Seasonal allergies, irritation prone, or CIE risk factors. So what would they be? The patients had prior inflammatory events. They're a smoker. They're a male teenager. So all of those are known to be positive risk factors for CIEs. So if any of those are true, then you see we go down to the proceed button on the yes, and our recommendation is 1-day AccuView Moist. If the answer is no, our recommendation then is to go and fit that patient with our AccuView Oasis 1-day. And as you know, both of those are available in both the sphere and a toric. So what if that prescription is not available as a daily disposable? That takes you to our reusable page, which is our next slide. And on this, again, first decision box here, are any of the following present? Less robust tear film. And Linda did a great job showing, measuring tear meniscus height, for example, maybe looking at the lipid layer. If you see something that there's an issue with that, or if the patient plans on using their contact lens in a challenging environment, dusty, dirty environment, for example, then if the answer is yes, we're saying then go to the next decision box, which is that patient light sensitive or bothered by light? If they are, then we feel AccuView Oasis with transitions is the ideal. If they aren't, then we're saying go into AccuView 2-week Oasis, remembering that's got also the extended wear approval, the class 1 UV blocker, and it is approved as a bandage lens. But if the patient does have that great robust tear film, they're not working in kind of that crummy environment, and they have an interest in a longer wear schedule, then they're a great patient for AccuView Vita. So hopefully you kind of see this decision tree could hopefully help give you some direction on what we feel are the best AccuView products for each individual patient. But once you've done all of this, the next really important thing is you've got to have the ability to sit there and communicate that with your patient. And to do that, I'm going to turn that over to you, Carol.
Thanks, Kurt. And we'll just go right on to the next slide. But it's important, right? We're talking about the lens selection that you're making so that you can prescribe the right lens for the right reasons to your patients. Unfortunately, in our fast-paced world, sometimes the easy button, if you will, in that recommendation is a quick observation about modality and price. If we can get to a better place, if we as practitioners can elevate our conversation to be more patient-focused, that then helps them better realize why, gee, they needed a doctor to get that prescription and how important that is to them in making sure that they have a lifetime of success in wearing contact lenses. So we've got yet another resource for you. It's a recommendation guide. You'll see that it kind of just gives you little hints: lifestyle, ocular factors, what's the prescription, and then what would my choice be within the AccuView portfolio. You could use any brand that you want, but we know our lenses. So you'll see this written up for AccuView. what I also love about the resources is that they are wonderful tools to use, not only for just you, but for your staff in a staff education kind of way. So if we go to the next slide, here's just a reminder of all of the things that are connected to everything we talked about today. So you'll see on your left, just it's a two-page, two sides to a page, information about the evidence that Dr. Jones shared with us. In the middle, yes, we have the pocket guide. You actually can fold it up in thirds and put it in your pocket that will house that decision tree. And again, in the bottom middle, you'll see that recommendation for conversation or communication guide. And then if you prefer, and I think this is a really nice resource, if you just want the decision tree on an 8.5 by 11 downloadable, you can get that too. So if we go to the next slide, it'll tell you exactly how to get what you need. So this is one of those times when take a screen grab because you want to remember this, but you just log into jnjvisionpro.com where you'll go from there. Then once you're logged in, go to the business center, click on that, click on promotional materials. You will find a bevy of really well put together resources for you. All of the ones you just saw there included as well. Download them to your heart's content, use them as often as you like. And we think that you'll have all the tools that you need for great reminders for yourself as clinicians, for your staff meetings, and really putting that beginning question back to the forefront. Why does lens selection matter? You know why it does, and we hope we've given you the tools to do even a better job than you've always been doing. And gentlemen, I know that we're up on time, so I'd like to give you both just a second to say a farewell if you'd like to.
Hey, good night, everybody. And I'd like to thank Covalent Careers for the opportunity.
Yeah, me too. Thanks very much. Thanks for chiming in and listening to us.
Thanks, everyone. And again, yes, my thanks on behalf of J&J Covalent Careers for allowing us to be part of ION 2021. And we wish everybody a great session and event, and more importantly, a very happy Thanksgiving. Thank you for joining us.